Chapter 5. Stupor and Coma. Definitions. Consciousness may be defined as a state of awareness of self and surroundings. Alterations in consciousness are conceptualized into two types. The first type affects arousal and is the subject of this chapter. Sleep, the only normal form of altered consciousness, is discussed in Chapter 101. The second type involves cognitive and affective mental function, sometimes referred to as the content of mental function. Examples of the latter type of alteration in consciousness are dementia. See Chapter 7, Delusions, Confusion, and Inattention. See Chapter 9. These altered states of consciousness, with the exception of advanced dementia, do not affect the level of arousal. Delirium is defined by American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSMV, as a disturbance in attention and awareness, European Delirium Association. Delirium can occur without a reduced level of consciousness, such as a hyperactive delirium, and in this context would be classified as a disorder of the content or mental function. Alternatively, delirium can occur in conjunction with a mildly or moderately reduced level of consciousness, such as hypoactive delirium, and would be classified as a disorder of arousal. Delirium is a good example of a confusional state in which it may be clinically difficult to separate decreased arousal from a change in cognitive or affective mental function. In clinical practice, the exact boundary between different forms of altered consciousness may be vague. Diagnostic criteria for delirium from the American Psychiatric Association's DSMV, in addition to a disturbance in attention and awareness, include an additional disturbance in cognition, memory, language, visual spatial ability, perception, that developed over hours to days as a change from the patient's baseline and is not better explained by a neurocognitive disorder. Patients with severely reduced levels of arousal, such as coma, cannot also be classified as delirious. Alterations in arousal, although often referred to as altered levels of consciousness, do not actually form discrete levels but rather are made up of a continuum of subtly changing behavioral states that range from alert to comatose. These states are dynamic and thus may change with time. 4 points on the continuum of arousal are often used in describing the clinical state of a patient: alert, lethargic, stuporous, and comatose. Alert refers to a perfectly normal state of arousal. Lethargy lies between alertness and stupor. Stupor is a state of baseline unresponsiveness that requires repeated application of vigorous stimuli to achieve arousal. Coma is a state of complete unresponsiveness to arousal. The terms lethargy and stupor cover a broad area on the continuum of behavioral states and thus are subject to misinterpretation by subsequent observers of a patient when used without further qualification. In clinical practice, in which relatively slight changes in arousal may be significant, only the terms alert and comatose, the endpoints of the continuum, have enough precision to be used without further qualification. Conditions that may mimic coma. Several different states of impaired cognition or consciousness may appear similar to coma or may be confused with it, Table 5.1. Moreover, patients who survive the initial coma may progress to certain of these syndromes after varying lengths of time. Once sleep-wake cycles become established, true coma is no longer present. Differentiation of these states from true coma is important to allow administration of appropriate therapy and to help determine prognosis. In the locked-in syndrome, deafferented state, patients are alert and aware of their environment but are quadriplegic, with lower cranial nerve palsies resulting from bilateral ventral pontine lesions that involve the corticospinal, corticopontine, and corticobulbar tracts. The patients are awake and alert but are voluntarily able only to move their eyes vertically or blink. The locked-in syndrome most often is observed as a consequence of pontine infarction due to basilar artery thrombosis. Other causes include central pontine myelinolysis and brainstem mass lesions. A state similar to the locked-in syndrome also may be seen with severe polyneuropathy, in particular, acute inflammatory demyelinating polyradiculon neuropathy, myasthenia gravis, and poisoning with neuromuscular blocking agents. In the persistent vegetative state, PVS, patients do not demonstrate clinically the ability to engage in any of the following behaviors: awareness of self and environment, interaction with others, sustained, reproducible, or purposeful voluntary behavioral response to visual, auditory, tactile or noxious stimuli, language comprehension or expression, or blink to visual threat. However, these patients do retain vegetative functions such as cardiac action, respiration, maintenance of blood pressure, and a sleep-wake cycle. Spontaneous movements may occur and the eyes may open in response to external stimuli, but the patient does not speak or obey commands. Functional magnetic resonance imaging, MRI, and electroencephalogram, EEG, studies of patients who meet the aforementioned clinical criteria of PVS have shown that approximately 14% of these patients will activate brain regions similar to healthy subjects when following commands despite not being able to demonstrate clinically these behaviors. Diagnostic criteria for PVS are provided in Table 5.2. The diagnosis of this condition should be made cautiously and only after extended periods of observation. A number of poorly defined syndromes have been used synonymously with PVS, including Apallic syndrome or state, akinetic mutism, coma vigil, alpha coma, neocortical death, and permanent unconsciousness. These terms, used variously by different authors, probably are best avoided because of their lack of precision. A condition that has been estimated to be 10 times more common than PVS is the minimally conscious state, in which severe disability accompanies minimal awareness. A set of diagnostic criteria for the minimally conscious state have proposed, Table 5.3. In 2 separate studies in Europe, more than 40% of patients in a minimally conscious state were misdiagnosed as PVS, most commonly due to lack of appreciation of eye tracking. Some authors subdivide minimally conscious state into minimally conscious state plus for patients who demonstrated higher level function such as command following or intelligible speech, and minimally conscious state minus for patients who only rely to environmental stimuli or visually track objects. Similar to PVS patients, functional MRI and EEG studies of patients who meet the clinical criteria minimally conscious state have shown that approximately 32% of these patients will activate brain regions similar to healthy subjects when following commands despite not being able to demonstrate clinically these behaviors. Emergence from minimally conscious state occurs when there is recovery of appropriate yes or no answers to questions or when able to use 2 familiar objects correctly. Abulia is a severe apathy in which patients have blunting of feeling, drive, mentation, and behavior such that they neither speak nor move spontaneously. Catatonia may result in a state of muteness, with dramatically decreased motor activity. The maintenance of body posture, with preserved ability to sit or stand, distinguishes it from organic pathological stupor. It generally is a psychiatric manifestation but may be mimicked by frontal lobe dysfunction or drug effect. Pseudocoma is the term for a condition in which the patient appears comatose, i.e., unresponsive, unarousable, or both, but has no structural, metabolic, or toxic disorder. Approach to the patient in coma. The initial clinical approach to the patient in a state of stupor or coma is based on the principle that all alterations in arousal constitute acute, life-threatening emergencies until vital functions such as blood pressure and oxygenation are stabilized, potentially reversible causes of coma are treated, and the underlying cause of the alteration in arousal is understood. Urgent steps may be necessary to avoid or minimize permanent brain damage from reversible causes. In view of the urgency of this situation, every physician should develop a diagnostic and therapeutic routine to use with a patient with an alteration in consciousness. A basic understanding of the mechanisms that lead to impairment in arousal is necessary to develop this routine. The anatomical and physiological basis for alterations in arousal are discussed in Chapter 101. Although it is essential to keep in mind the concept of a spectrum of arousal, for the sake of simplicity and brevity only the term coma is used in the rest of this chapter. Table 5.4 lists many of the common causes of coma. More than half of all cases of coma are due to diffuse and metabolic brain dysfunction. In Plum and Posner's landmark study, 1980, see 2007 revision, of 500 patients initially diagnosed as having coma of unknown cause, in whom the diagnosis was ultimately established, 326 patients had diffuse and metabolic brain dysfunction. Almost half of these had drug poisonings. Of the remaining patients, 101 had supratentorial mass lesions, including 77 hemorrhagic lesions and 9 infarctions, 65 had subtentorial lesions, mainly brainstem infarctions, and 8 had psychiatric coma. A logical decision tree often used in searching for the cause of coma divides the categories of diseases that cause coma into 3 groups: structural lesions, which may be above or below the tentorium, metabolic and toxic causes, and psychiatric causes. The history and physical examination usually provide sufficient evidence to determine the presence or absence of a structural lesion and quickly differentiate the general categories to decide what further diagnostic tests are needed or to allow for immediate intervention if necessary. Serial examinations are needed, with precise description of the behavioral state at different points in time, to determine if the patient is improving or, a more ominous finding, worsening, and to decide if a change in therapy or further diagnostic tests is necessary. Subtle declines in the intermediate states of arousal may herald precipitous changes in brainstem function, which may affect regulation of vital functions such as respiration or blood pressure. The dynamic quality of alterations of consciousness and the need for accurate documentation at different points in time cannot be overemphasized. Rapid initial examination and emergency therapy. A relatively quick initial assessment is conducted to ensure that the comatose patient is medically and neurologically stable before a more detailed investigation is undertaken. This rapid initial examination is essential to rule out the need for immediate medical or surgical intervention. In addition, various supportive or preventive measures may be indicated. Urgent and sometimes empirical therapy is given to prevent further brain damage. Potential immediate metabolic needs of the brain are supplied by empirical use of supplemental oxygen, intravenous thiamine, at least 100 mg, and intravenous 50% dextrose in water, 25 grams. A baseline serum glucose level should be obtained before glucose administration. The use of intravenous glucose in patients with ischemic or anoxic brain damage is controversial. Extra glucose may augment local lactic acid production by anaerobic glycolysis and may worsen ischemic or anoxic damage. However, clinically, empirical glucose administration is recommended when the cause of coma is unknown. There are 2 reasons for this approach: the frequent occurrence of alterations in arousal due to hypoglycemia and the relatively good prognosis for coma due to hypoglycemia when it is treated expeditiously, and the potentially permanent consequences if it is not treated. By comparison, the prognosis for anoxic or ischemic coma generally is poor and probably will remain poor regardless of glucose supplementation. Thiamine must always be given in conjunction with glucose to prevent precipitation of Wernicke encephalopathy. Naloxone hydrochloride may be given parenterally, preferably intravenously, in doses of 0.4 to 2.0 mg if opiate overdose is the suspected cause of coma. An abrupt and complete reversal of narcotic effect may precipitate an acute abstinence syndrome in persons who are physically dependent on opiates. An initial examination should include a check of general appearance, blood pressure, pulse, temperature, respiratory rate and breath sounds, best response to stimulation, pupil size and responsiveness, and posturing or adventitious movements. The neck should be stabilized in all instances of trauma until cervical spine fracture or subluxation can be ruled out. The airway should be protected in all comatose patients and an intravenous line placed. However, in coma, the classic sign of an acute condition in the abdomen, namely, abdominal rigidity, may be subtle in degree or absent. In addition, the diagnosis of blunt abdominal trauma is difficult in patients with a change in mental status. Therefore, in unconscious patients with a history of trauma, a computed tomography, CT, scan of the abdomen or peritoneal lavage by an experienced surgeon may be warranted. Hypotension, marked hypertension, bradycardia, arrhythmias causing depression of blood pressure, marked hyperthermia, and signs of cerebral herniation mandate immediate therapeutic intervention. Hyperthermia or meningismus prompts consideration of urgent lumbar puncture. Examination of the fundus of the eye for papilledema and a CT scan of the brain should be performed before lumbar puncture in any comatose patient. Infection at the site of the lumbar puncture, papilledema, decerebrate posturing, and thrombocytopenia and other bleeding diathesis are contraindications to lumbar puncture, and, even in their absence, medico-legal considerations may render a CT scan of the head preferable before proceeding to lumbar puncture. To avoid a delay in therapy when acute bacterial meningitis is strongly suspected, antibiotics and adjunctive corticosteroids should be administered within 1 hour of hospital admission. Brower et al. 2010. Even if cerebrospinal fluid, CSF, collection cannot be obtained in a timely fashion. Corticosteroid administration should be avoided in the presence of septic shock. Blood cultures and throat swabs should be obtained on these patients prior to antibiotic administration. The risk of herniation from a lumbar puncture in patients with evidence of increased intracerebral pressure is difficult to ascertain from the literature. Estimates range from 1% to 12%, depending on the series, Posner et al. 2007. It is important to recognize that both central and tonsillar herniation may increase neck tone. Despite an elevated intracranial pressure, ICP, sufficient CSF should always be obtained to perform the necessary studies. The performance of bacterial culture and cell count, essential in cases of suspected bacterial meningitis, requires but a few milliliters of fluid. Multiplex nucleic acid amplification tests may be helpful in diagnosing a central nervous system, CNS, infection, especially when caused by fastidious or noncultivable microorganisms. Intravenous access and intravenous mannitol or hypertonic saline should be ready in the event that unexpected herniation begins after the lumbar puncture. When the CSF pressure is greater than 500 mm H2O, some authorities recommend leaving the needle in place to monitor the pressure and administering intravenous mannitol or hypertonic saline to lower the pressure. If focal signs develop during or after the lumbar puncture, immediate intubation and hyperventilation also may be necessary to reduce intracerebral pressure urgently until more definitive therapy is available. Ecchymosis, petechia, or evidence of ready bleeding on general examination may indicate coagulation abnormality or thrombocytopenia. This increases the risk of epidural hematoma after a lumbar puncture, which may cause devastating spinal cord compression. Measurements of prothrombin time, partial thromboplastin time, and platelet count should precede lumbar puncture in these cases, and the coagulation abnormality or thrombocytopenia should be corrected before proceeding to lumbar puncture. Common presentations. Coma usually manifests in one of three ways. First, and most commonly, it occurs as an expected or predictable progression of an underlying illness. Examples are focal brainstem infarction with extension, chronic obstructive pulmonary disease in a patient who is given too high a concentration of oxygen, thereby decreasing respiratory drive and resulting in carbon dioxide narcosis, and known barbiturate overdose when the ingested drug cannot be fully removed and begins to cause unresponsiveness. Second, coma occurs as an unpredictable event in a patient whose prior medical conditions are known to the physician. The coma may be a complication of an underlying medical illness, such as in a patient with arrhythmia who suffers anoxia after a cardiac arrest. Alternatively, an unrelated event may occur, such as sepsis from an intravenous line in a cardiac patient or a stroke in a hypothyroid patient. Third, coma can occur in a patient whose medical history is totally unknown to the physician. Sometimes this type of presentation is associated with a known probable cause, such as head trauma incurred in a motor vehicle accident, but often the comatose patient presents to the physician without an obvious associated cause. Thorough objective systematic assessment must be applied in every comatose patient. Special care must be taken not to be lulled or misled by an apparently predictable progression of an underlying illness or other obvious cause of coma. History. Once the patient is relatively stable, clues to the cause of the coma should be sought by briefly interviewing relatives, friends, bystanders, or medical personnel who may have observed the patient before or during the decrease in consciousness. Telephone calls to family members may be helpful. The patient's wallet or purse should be examined for lists of medications, a physician's card, or other information. Attempts should be made to ascertain the patient's social background and prior medical history and the circumstances in which the patient was found. The presence of drug paraphernalia or empty medicine bottles suggests a drug overdose. Newer recreational drugs, such as gamma-hydroxybutyrate and bath salts, must be considered in the differential diagnosis. An oral hypoglycemic agent or insulin in the medicine cabinet or refrigerator implies possible hypoglycemia. Antiarrhythmic agents such as procainamide or quinidine suggest existing coronary artery disease with possible myocardial infarction or warn that an unwitnessed arrhythmia may have caused cerebral hypoperfusion, with resulting anoxic encephalopathy. Oral anticoagulants, including direct thrombin inhibitors, factor XA inhibitors, and warfarin, typically prescribed for patients with deep venous thrombosis or pulmonary embolism, atrial fibrillation or mechanical heart valve, may be responsible for massive intracerebral bleeding. In patients found to be unresponsive at the scene of an accident, the unresponsive state may be due to trauma incurred in the accident, or sudden loss of consciousness may have precipitated the accident. The neurologist often is called when patients do not awaken after surgery or when coma supervenes following a surgical procedure. Postoperative causes of coma include many of those mentioned in Table 5.4. In addition, the physician also must have a high index of suspicion for certain neurological conditions that occur in this setting, including fat embolism, Addisonian crisis, and hypothyroid coma, precipitated by acute illness or surgical stress, Wernicke encephalopathy from carbohydrate loading without adequate thiamine stores, and iatrogenic overdose of a narcotic analgesic. Attempts should be made to ascertain if the patient complained of symptoms before onset of coma. Common signs and symptoms include headache preceding subarachnoid hemorrhage, chest pain with aortic dissection or myocardial infarction, shortness of breath from hypoxia, stiff neck in meningoencephalitis, and vertigo in brainstem stroke. Nausea and vomiting are common in poisonings. Coma also may be secondary to increased ICP. Observers may have noted head trauma, drug abuse, seizures, or hemiparesis. Descriptions of falling to one side, dysarthria or aphasia, PTOSIS, pupillary dilatation, or disconjugate gaze may help to localize structural lesions. The time course of the disease, as noted by family or friends, may help to differentiate the often relatively slow, progressive course of toxic metabolic or infectious causes from abrupt, catastrophic changes that are seen most commonly with vascular events. Finally, family members or friends may be invaluable in identifying psychiatric causes of unresponsiveness. The family may describe a long history of psychiatric disease, previous similar episodes from which the patient recovered, current social stresses on the patient, or the patient's unusual, idiosyncratic response to stress. Special care must be taken with psychiatric patients because of the often biased approach to these patients, which may lead to incomplete evaluation. Psychiatric patients are subject to all of the causes of coma listed in Table 5.4. General examination. A systematic, detailed general examination is especially helpful in the approach to the comatose patient, who is unable to describe prior or current medical problems. This examination begins in the initial rapid examination with evaluation of blood pressure, pulse, respiratory rate, and temperature. Blood pressure evaluation. Hypotension. Cerebral hypoperfusion secondary to hypotension may result in coma if the mean arterial pressure decreases to less than the value for which the brain is able to autoregulate, normally 60 mm Hg. This value is substantially higher in chronically hypertensive persons, in whom the cerebral blood flow mean arterial pressure curve is shifted to the right. Among the causes of hypotension are hypovolemia, massive external or internal hemorrhage, myocardial infarction, cardiac tamponade, dissecting aortic aneurysm, intoxication with alcohol or other drugs, especially barbiturates, toxins, Wernicke encephalopathy, Addison disease, and sepsis. Although most patients with hypotension are cold because of peripheral vasoconstriction, patients with Addison disease or sepsis may have warm shock due to peripheral vasodilation. Medullary damage also may result in hypotension because of damage to the pressor center. Hypertension. Hypertension is the cause of alterations in arousal in hypertensive crisis and is seen secondarily as a response to cerebral infarction, in subarachnoid hemorrhage, with certain brainstem infarctions, and with increased intracerebral pressure. The Coker-Cushing, or Claude-Bernard, reflex is the development of hypertension associated with bradycardia and respiratory irregularity due to increased ICP. This response occurs more commonly in the setting of a posterior fossa lesion and in children. It results from compression or ischemia of the pressor area lying beneath the floor of the fourth ventricle. Hypertension is a common condition and thus may be present but unrelated to the cause of coma. Heart rate. In addition to the Coker-Cushing reflex, bradycardia can result from myocardial conduction blocks, with certain poisonings, and from effects of drugs such as the beta blockers. Tachycardia is a result of hypovolemia, hyperthyroidism, fever, anemia, and certain toxins and drugs, including cocaine, atropine, and other anticholinergic medications. Respiration. The most common causes of decreased respiratory rate are metabolic or toxic, such as carbon dioxide narcosis or drug overdose with CNS depressants. Increased respiratory rate can result from hypoxia, hypercapnia, acidosis, hyperthermia, hepatic disease, toxins or drugs, especially those that produce a metabolic acidosis, such as methanol, ethylene glycol, paraldehyde, and salicylates, sepsis, and pulmonary embolism, including fat embolism, and sometimes is seen in psychogenic unresponsiveness. Brainstem lesions causing hypopnea or hyperpnea are discussed later in the chapter. Changes in respiratory rate or rhythm in a comatose patient may be deceiving, because a metabolic disorder may coexist with a CNS lesion. Temperature. Core temperature is best measured with a rectal probe in a comatose patient because oral or axillary temperatures are unreliable. Pyrexia most often is a sign of infection. Accordingly, any evidence of fever in a comatose patient warrants strong consideration of lumbar puncture. Absence of an elevated temperature does not rule out infection. Immunosuppressed patients, elderly patients, and patients with metabolic or endocrine abnormalities such as uremia or hypothyroidism may not experience an increase in temperature in response to overwhelming infection. Pure neurogenic hyperthermia is rare and usually is due to subarachnoid hemorrhage or diencephalic, hypothalamus, lesions. A clue to brainstem origin is shivering without sweating. Shivering in the absence of sweating, particularly when unilateral in nature, also may be observed with a deep intracerebral hemorrhage. Other causes of increased temperature associated with coma are heat stroke, thyrotoxic crisis, and drug toxicity. Atropine and other anticholinergics elevate core temperature but decrease diaphoresis, resulting in a warm, dry patient with dilated pupils and diminished bowel sounds. Except in heat stroke and malignant hyperthermia, fever does not result in stupor or coma by itself. Conversely, hypothermia, regardless of cause, is anticipated to lead to altered consciousness. Hypothermia causes diminished cerebral metabolism and, if the temperature is sufficiently low, may result in an isoelectric EEG. Hypothermia usually is metabolic or environmental in cause, however, it also is seen with hypotension accompanied by vasoconstriction and may occur with sepsis. Other causes of hypothermia associated with coma are hypothyroid coma, hypopituitarism, Wernicke encephalopathy, cold exposure, drugs, barbiturates, and other poisonings. Central lesions causing hypothermia are found in the posterior hypothalamus. The absence of shivering or vasoconstriction, or the presence of sweating, is a clue to the central origin of these lesions. General appearance. The general appearance of the patient may provide further clues to the diagnosis. Torn or disheveled clothing may indicate prior assault. Vomiting may be a sign of increased ICP, drug overdose, or metabolic or other toxic cause. Urinary or fecal incontinence suggests an epileptic seizure or may result from a generalized autonomic discharge resulting from the same cause as for the coma. Examination of body habitus may reveal Cushingoid patients at risk for an acute Addisonian crisis with abrupt withdrawal of their medications or additional stress from intercurrent illness. Cachexia suggests cancer, chronic inflammatory disorders, Addison disease, hypothyroid coma, or hyperthyroid crisis. The cachectic patient also is subject to Wernicke encephalopathy in association with carbohydrate loading. Gynecomastia, spider nevi, testicular atrophy, and decreased axillary and pubic hair are common in the alcoholic with cirrhosis. Head and neck examination. The head and neck must be carefully examined for signs of trauma. Palpation for depressed skull fractures and edema should be attempted, although this means of evaluation is not very sensitive. Laceration or edema of the scalp is indicative of head trauma. The term raccoon eyes refers to orbital ecchymosis due to anterior basal skull fracture. Battle sign is a hematoma overlying the mastoid, originating from basilar skull fracture extending into the mastoid portion of the temporal bone. The ecchymotic lesions typically are not apparent until 2 to 3 days after the traumatic event. Meningismus, or neck stiffness, may be a sign of infectious or carcinomatous meningitis, subarachnoid hemorrhage, or central or tonsillar herniation. However, neck stiffness may be absent in coma from any cause but is likely to be present in less severe alterations in arousal. Scars on the neck may be from endarterectomy, implying vascular disease, or from thyroidectomy or parathyroidectomy, suggesting concomitant hypothyroidism, hypoparathyroidism, or both. Goiter may be found with hypothyroidism or hyperthyroidism. Eye examination. Examination of the eyes includes observation of the cornea, conjunctiva, sclera, iris, lens, and eyelids. Edema of the conjunctiva and eyelids may occur in congestive heart failure and nephrotic syndrome. Congestion and inflammation of the conjunctiva may occur in the comatose patient from exposure. Enophthalmos indicates dehydration. Scleral icterus is seen with liver disease, and yellowish discoloration of the skin without scleral involvement may be due to drugs such as rifampin. Band keratopathy is caused by hypercalcemia, whereas hypocalcemia is associated with cataracts. Kayser-Fleischer rings are seen in progressive lenticular degeneration, Wilson disease. Arcus senilis is seen in normal aging but also in hyperlipidemia. Fat embolism may cause petechia not only in skin of the upper body and oral mucosa but also in conjunctiva and eye grounds. Funduscopic examination may demonstrate evidence of hypertension or diabetes. Grayish deposits surrounding the optic disc have been reported in lead poisoning. The retina is congested and edematous in methyl alcohol poisoning, and the disc margin may be blurred. Subhyaloid hemorrhage appears occasionally as a consequence of a rapid increase in ICP due to subarachnoid hemorrhage, Terson syndrome. Papilledema results from increased ICP and may be indicative of an intracranial mass lesion or hypertensive encephalopathy. Otoscopic examination. Otoscopic examination should rule out hematympanum or CSF autoria from a basilar skull fracture involving the petrous ridge, as well as infection of the middle ear. Infections of the middle ear, mastoid, and paranasal sinuses constitute the most common source of underlying infection in brain abscess. CSF rhinorrhea, which appears as clear fluid from the nose, may depend on head position. The presence of glucose in the watery discharge is virtually diagnostic, although false positive results are possible. Oral examination. Alcohol intoxication, diabetic ketoacidosis, acetone odor, uremia, and hepatic encephalopathy, musty odor of cholemia or fetor hepaticus, may be suspected from the odor of the breath. Arsenic poisoning produces the odor of garlic. Poor oral hygiene or oral abscesses may be a source of sepsis or severe pulmonary infection with associated hypoxemia. Pustules on the nose or upper lip may seed the cavernous sinus with bacteria by way of the angular vein. Lacerations on the tongue, whether old or new, suggest seizure disorder. Thin, blue-black pigmentation along the gingival margin may be seen in certain heavy metal poisonings, bismuth, mercury, and lead. Integument examination. Systematic examination of the integument includes inspection of the skin, nails, and mucous membranes. A great deal of information can be gained by a brief examination of the skin, Table 5.5. Hot, dry skin is a feature of heat stroke. Sweaty skin is seen with hypotension or hypoglycemia. Drugs may cause macular papular, vesicular, or petechial purpuric rashes or bullous skin lesions. Bullous skin lesions most often are a result of barbiturates but also may be caused by imipramine, meprobamate, glutathione, phenothiazine, and carbon monoxide. Kaposi sarcoma, anogenital herpetic lesions, or oral candidiasis should suggest the acquired immunodeficiency syndrome, AIDS, with its plethora of CNS abnormalities. Examination of lymph nodes. Generalized lymphadenopathy is nonspecific, because it may be seen with neoplasm, infection, including AIDS, collagen vascular disease, sarcoid, hyperthyroidism, Addison disease, and drug reaction, especially that due to phenytoin. However, local lymph node enlargement or inflammation may provide clues to a primary tumor site or source of infection. Cardiac examination. Cardiac auscultation will confirm the presence of arrhythmias such as atrial fibrillation, with its inherent increased risk of emboli. Changing mitral murmurs are heard with atrial myxomas and papillary muscle ischemia, which is seen with current or impending myocardial infarction. Constant murmurs indicate valvular heart disease and may be heard with the valvular vegetation of bacterial endocarditis. Abdominal examination. Possibly helpful findings on abdominal examination include abnormal bowel sounds, organomegaly, masses, and ascites. Bowel sounds are absent in an acute abdominal condition, as well as with anticholinergic poisoning. Hyperactive bowel sounds may be a consequence of increased gastrointestinal motility from exposure to an acetylcholine esterase inhibitor, a common pesticide ingredient. The liver may be enlarged as a result of right heart failure or tumor infiltration. Nodules or a rock-hard liver may be due to hepatoma or metastatic disease. The liver may be small and hard in cirrhosis. Splenomegaly is caused by portal hypertension, hematological malignancies, infection, and collagen vascular diseases. Intraabdominal masses may indicate carcinoma. Ascites occurs with liver disease, right heart failure, neoplasms with metastasis to the liver, or ovarian cancer. Miscellaneous examinations. A positive result on tests for blood in stool obtained at rectal examination is consistent with gastrointestinal bleeding and, possibly, bowel carcinoma. Large amounts of blood in the gastrointestinal tract may be sufficient to precipitate hepatic encephalopathy in the patient with cirrhosis. Neurological examination. Neurological signs may vary depending on the cause of the impaired consciousness and its severity, and they may be partial or incomplete. For example, the patient may have a partial third nerve palsy with pupillary dilation, rather than a complete absence of all third nerve function, or muscle tone may be decreased but not absent. This concept is especially important in the examination of the stuporous or comatose patient because the level of arousal may also influence the expression of neurological signs. In the stuporous or comatose patient, even slight deviations from normal should not be dismissed as unimportant. Such findings should be carefully considered to discover their pattern or meaning. The neurological examination of a comatose patient serves three purposes: 1. To aid in determining the cause of coma, 2. To provide a baseline, and 3. To help determine the prognosis. For prognosis and localization of a structural lesion, the following components of the examination have been found to be most helpful: state of consciousness, respiratory pattern, pupillary size in response to light, spontaneous and reflex eye movements, and skeletal muscle motor response. State of consciousness. The importance of a detailed description of the state of consciousness is worth re-emphasizing. It is imperative that the exact stimulus and the patient's specific response be recorded. Several modes of stimulation should be used, including auditory, visual, and noxious. Stimuli of progressively increasing intensity should be applied, with the maximal state of arousal noted in the stimuli, the site of stimulation, and the patient's exact response described. The examiner should start with verbal stimuli, softly and then more loudly calling the patient's name or giving simple instructions to open the eyes. If there is no significant response, more threatening stimuli, such as taking the patient's hand and advancing it toward the patient's face, are applied. However, a blink response to visual threat need not indicate consciousness. Finally, painful stimuli may be needed to arouse the patient. All patients in apparent coma should be asked to open or close the eyes and to look up and down. These voluntary movements are preserved in the locked-in syndrome but cannot be elicited in coma, an important distinction. Supraorbital pressure evokes a response even in patients who may have lost afferent pain pathways as a result of peripheral neuropathy or spinal cord or some brainstem lesions. Nail bed pressure or pinching the chest or extremities may help to localize a lesion when it evokes asymmetrical withdrawal responses. Care must be taken to avoid soft tissue damage. Purposeful movements indicate a milder alteration in consciousness. Vocalization to pain in the early hours of a coma, even if only a grunt, indicates relatively light alteration in consciousness. Later, primitive vocalization may be a feature of the vegetative state. The Glasgow Coma Scale, Table 5.6, is used widely to assess the initial severity of traumatic brain injury. This battery assesses three separate aspects of a patient's behavior: the stimulus required to induce eye-opening, the best motor response, and the best verbal response. Degrees of increasing dysfunction are scored. Its reproducibility and simplicity make the Glasgow Coma Scale an ideal method of assessment for non-neurologists involved in the care of comatose patients. However, its failure to assess other essential neurological parameters limits its utility. In addition, in patients who are intubated or who have suffered facial trauma, assessment of certain components of the Glasgow Coma Scale, such as eye-opening and speech, may be difficult or impossible. An alternative scale referred to as the full outline of unresponsiveness score has been proposed, Vadix et al. 2005, and is based on eye response, motor response, brainstem reflexes, pupillary reaction, corneal reflex, and cough reflex, and respirations. Respiration. Normal breathing is quiet and unlabored. The presence of any respiratory noise implies airway obstruction, which must be dealt with immediately to prevent hypoxia. Normal respiration depends on 1. A brainstem mechanism, located between the midpons and cervical medullary junction, that regulates metabolic needs, and 2. Forebrain influences that subserve behavioral needs such as speech production. The organization and function of brainstem mechanisms responsible for respiratory rhythm generation, as well as forebrain influences, are complex and beyond the scope of this chapter. Neuropathological correlates of respiration are presented in Fig. 5.1. Respiratory patterns that are helpful in localizing levels of involvement include Cheyne-Stokes respiration, central neurogenic hyperventilation, apneustic breathing, cluster breathing, and ataxic respiration. Cheyne-Stokes respiration is a respiratory pattern that slowly oscillates between hyperventilation and hypoventilation. In 1818, Cheyne described his patient as follows: for several days his breathing was irregular. It would entirely cease for a quarter of a minute, then it would become perceptible, though very low, then by degrees it became heaving and quick, and then it would gradually cease again. This revolution in the state of his breathing occupied about a minute, during which there were about 30 acts of respiration. Cheyne-Stokes respiration is associated with bilateral hemispheric or diencephalic insults, but it may occur as a result of bilateral damage anywhere along the descending pathway between the forebrain and upper pons. It also is seen with cardiac disorders that prolong circulation time. Alertness, pupillary size, and heart rhythm may vary during Cheyne-Stokes respiration. Posner et al. 2007. Patients are more alert during the waxing portion of breathing. A continuous pattern of Cheyne-Stokes respiration is a relatively good prognostic sign, usually implying that permanent brainstem damage has not occurred. However, the emergence of Cheyne-Stokes respiration in a patient with a unilateral mass lesion may be an early sign of herniation. A change in pattern from Cheyne-Stokes respiration to certain other respiratory patterns, described next, is ominous. Two breathing patterns similar to Cheyne-Stokes respiration should not be confused with it. Short cycle periodic breathing is a respiratory pattern with a shorter cycle, faster rhythm, than Cheyne-Stokes respiration, with 1 or 2 waxing breaths, followed by 2 to 4 rapid breaths, then 1 or 2 waning breaths. It is seen with increased ICP, lower pontine lesions, or expanding lesions in the posterior fossa. Posner et al. 2007. A similar type of respiration, in which there are short bursts of 7 to 10 rapid breaths, then apnea without a waning and waxing prodrome, has been erroneously referred to as BO breathing. BO, in fact, described an ataxic respiratory pattern, which is described later. Central neurogenic hyperventilation refers to rapid breathing, from 40 to 70 breaths per minute, usually due to central tegmental pontine lesions just ventral to the aqueduct or fourth ventricle. Posner et al. 2007. This type of breathing is rare and must be differentiated from reactive hyperventilation due to metabolic abnormalities of hypoxemia secondary to pulmonary involvement. Large CNS lesions may cause neurogenic pulmonary edema, with associated hypoxemia and increased respiratory rate. Increased intracerebral pressure causes spontaneous hyperpnea. Hyperpnea cannot be ascribed to a CNS lesion when arterial oxygen partial pressure is less than 70 to 80 mm Hg or carbon dioxide partial pressure is greater than 40 mm Hg. Kussmaul breathing is a deep, regular respiration observed with metabolic acidosis. Apneustic breathing is a prolonged inspiratory gasp with a pause at full inspiration. It is caused by lesions of the dorsolateral lower half of the pons. Posner et al. 2007. Cluster breathing, which results from high medullary damage, involves periodic respirations that are irregular in frequency and amplitude, with variable pauses between clusters of breaths. Ataxic breathing is irregular in rate and rhythm and usually is due to medullary lesions. The combination of ataxic respiration and bilateral sixth nerve palsy may be a warning sign of brainstem compression from an expanding lesion in the posterior fossa. This is an important sign because brainstem compression due to tonsillar herniation, or other causes, may result in abrupt loss of respiration or blood pressure. Ataxic and gasping respirations are signs of lower brainstem damage and often are preterminal respiratory patterns. Pupil size and reactivity. Normal pupil size in the comatose patient depends on the level of illumination in the state of autonomic innervation. The sympathetic efferent innervation consists of a 3-neuron arc. The first-order neuron arises in the hypothalamus and travels IPSI laterally through the posterolateral tegmentum to the ciliospinal center of Budge at the T1 level of the spinal cord. The second-order neuron leaves this center and synapses in the superior cervical sympathetic ganglion. The third-order neuron travels along the internal carotid artery and then through the ciliary ganglion to the pupillodilator muscles. The parasympathetic efferent innervation of the pupil arises in the Edinger-Westphal nucleus and travels in the oculomotor nerve to the ciliary ganglion, from which it innervates the pupillosphincter muscle. Fig. 5.2. Afferent input to the pupillary reflex depends on the integrity of the optic nerve, optic chiasm, optic tract, and projections into the midbrain tectum and efferent fibers through the Edinger-Westphal nucleus and oculomotor nerve. Abnormalities in pupil size and reactivity help to delineate structural damage between the thalamus and pons. Fig. 5.3. Act as a warning sign heralding brainstem herniation, and help to differentiate structural causes of coma from metabolic causes. Thalamic lesions cause small, reactive pupils, which often are referred to as diencephalic pupils. Similar pupillary findings are noted in many toxic metabolic conditions resulting in coma. Hypothalamic lesions or lesions elsewhere along the sympathetic pathway result in Horner syndrome. Midbrain lesions produce three types of pupillary abnormality, depending on where the lesion occurs. 1. Dorsal tectal lesions interrupt the pupillary light reflex, resulting in midposition pupils, which are fixed to light but react to near vision. The latter is impossible to test in the comatose patient. Spontaneous fluctuations in size occur, and the ciliospinal reflex is preserved. 2. Nuclear midbrain lesions usually affect both sympathetic and parasympathetic pathways, resulting in fixed, irregular midposition pupils, which may be unequal. 3. Lesions of the third nerve fascicle in the brainstem, or after the nerve has exited the brainstem, cause wide pupillary dilation, unresponsive to light. Pontine lesions interrupt sympathetic pathways and cause small, so-called pinpoint pupils, which remain reactive, although magnification may be needed to observe this feature. Lesions above the thalamus and below the pons should leave pupillary function intact, except for Horner syndrome in medullary or cervical spinal cord lesions. The pathophysiology of pupillary response is discussed further in Chapter 17. Asymmetry in pupillary size or reactivity, even of minor degree, is important. Asymmetry of pupil size may be due to dilation, mydriasis, of one pupil, such as with third nerve palsy, or contraction, miosis, of the other, as in Horner syndrome. This may be differentiated by the pupillary reactivity to light and associated neurological signs. A dilated pupil due to a partial third nerve palsy is less reactive and usually is associated with extraocular muscle involvement. The pupil in Horner syndrome is reactive. If the syndrome results from a lesion in the CNS, it may be associated with anhidrosis of the entire ipsilateral body. Cervical sympathetic chain lesions produce anhidrosis of only face, neck, and arm. A partial or complete third nerve palsy causing a dilated pupil may result from an intramedullary lesion, most commonly in the midbrain, such as an intramedullary glioma or infarction, uncal herniation compressing the third nerve, or a posterior communicating artery aneurysm. A sluggishly reactive pupil may be one of the first signs of uncal herniation, followed soon thereafter by dilation of that pupil and, later, complete third nerve paralysis. Several caveats are important in examining the pupil or assessing pupillary reflexes. A common mistake is the use of insufficient illumination. The ophthalmoscope may be useful in this regard because it provides both adequate illumination and magnification. Rarely, pre-existing ocular or neurological injury may fix the pupils or result in pupillary asymmetry. Seizures may cause transient anisocoria. Local and systemic medications may affect pupillary function. Topical ophthalmological preparations containing an acetylcholinesterase inhibitor, used in the treatment of glaucoma, produce miosis. The effect of a mydriatic agent placed by the patient or a prior observer may wear off unevenly, resulting in pupillary asymmetry. Some common misleading causes of a unilateral dilated pupil include prior mydriatic administration, old ocular trauma or ophthalmic surgery, and, more rarely, carotid artery insufficiency. Ocular motility. Normal ocular motility, see chapters 18 and 21, depends on the integrity of a large portion of the cerebrum, cerebellum, and brainstem. Preservation of normal ocular motility implies that a large portion of the brainstem from the vestibular nuclei at the pontomedullary junction to the oculomotor nucleus in the midbrain is intact. Voluntary ocular motility cannot be judged in the comatose patient, so the examiner must rely on reflex eye movements that allow for assessment of the ocular motor system. The eye movements normally are conjugate, and eyes are in the mid-position in the alert person. Sleep or obtundation alone may unmask a latent vertical or horizontal strabismus, resulting in disconjugacy. Therefore, patients must be examined when maximally aroused. The eyes return to the mid-position in brain-dead patients. Evaluation of ocular motility consists of 1. Observation of the resting position of the eyes, including eye deviation. 2. Notation of spontaneous eye movements. And 3. Testing of reflex ocular movements. Abnormalities in resting position. Careful attention must be paid to the resting position of the eyes. Even a small discrepancy in eye position may represent a partial extraocular nerve palsy. Partial nerve palsies or combined nerve palsies predictably result in a more complex picture on examination. Unilateral third nerve palsy from either an intramedullary midbrain lesion or extramedullary compression causes the affected eye to be displaced downward and laterally. A sixth nerve palsy produces inward deviation. However, Isolated sixth nerve palsy is a poor localizer because of the extensive course of the nerve and because this palsy may be caused by nonspecific increases in ICP, presumably from stretching of the extramedullary portion of the nerve. A fourth nerve palsy is difficult to assess in the comatose patient because of the subtle nature of the deficit in ocular motility. Extraocular nerve palsies often become more apparent with the doll's eye maneuver, our cold caloric testing in the comatose patient. Eye deviation. Spontaneous eye deviation may be conjugate or disconjugate. Conjugate lateral eye deviation usually is due to an ipsilateral lesion in the frontal eye fields but may be due to a lesion anywhere in the pathway from the ipsilateral eye fields to the contralateral peripontine reticular formation. See chapters 18 and 21. Disconjugate lateral eye movement may result from a sixth nerve palsy in the abducting eye, a third nerve palsy in the adducting eye, or an internuclear ophthalmoplegia. An internuclear ophthalmoplegia may be differentiated from a third nerve palsy by the preservation of vertical eye movements. Downward deviation of the eyes below the horizontal meridian usually is due to brainstem lesions, most often from tectal compression. However, it also may be seen in metabolic disorders such as hepatic coma. Thalamic and subthalamic lesions produce downward and inward deviation of the eyes. Patients with these lesions appear to be looking at the tip of the nose. Sleep, seizure, syncope, apnea of Cheyne-Stokes respiration, hemorrhage into the vermis, and brainstem ischemia or encephalitis cause upward eye deviation, making this a poor localizing sign. Skew deviation is a maintained deviation of one eye above the other, hypertropia, that is not due to a peripheral neuromuscular lesion or a local extracranial problem in the orbit. It usually indicates a posterior fossa lesion, brainstem or cerebellar. Disconjugate vertical eye position sometimes may occur in the absence of a brainstem lesion in the obtunded patient. Spontaneous eye movements. Spontaneous eye movements, see chapter 18, are of many types. Purposeful appearing eye movements in a patient who otherwise seems unresponsive should lead to consideration of the locked-in syndrome, catatonia, pseudocoma, or PVS. Roving eye movements or slow, conjugate, lateral to and fro movements. For roving eye movements to be present, the ocular motor nuclei and their connections must be intact. In general, when roving eye movements are present, the brainstem is relatively intact and coma is due to a metabolic or toxic cause or bilateral lesions above the brainstem. Detection of roving eye movements may be complicated by ocular palsies or internuclear ophthalmoplegia. These superimposed lesions produce relatively predictable patterns but often obscure the essential roving nature of the movement for the inexperienced observer. Nystagmus occurring in comatose patients suggests an irritative or epileptogenic supratentorial focus. An epileptogenic focus in one frontal eye field causes contralateral conjugate eye deviation. Nystagmus due to an irritative focus may rarely occur alone, without other motor manifestations of seizures. In addition, inconspicuous movements of the eye, eyelid, face, jaw, or tongue may be associated with electroencephalographic status epilepticus. An EEG is required to ascertain the presence of this condition. Spontaneous conjugate vertical eye movements are separated into different types according to the relative velocities of their downward and upward phases. In ocular bobbing, rapid downward jerks of both eyes are observed, followed by a brief pause in downgaze, followed by the slow return to the mid-position. In the typical form, there is associated paralysis of both reflex and spontaneous horizontal eye movements. Monocular or paretic bobbing occurs when a coexisting ocular motor palsy alters the appearance of typical bobbing. The term atypical bobbing refers to all other variations of bobbing that cannot be explained by an ocular palsy superimposed on typical bobbing. Most commonly, this term is used to describe ocular bobbing when lateral eye movements are preserved. Typical ocular bobbing is specific but not pathognomonic for acute pontine lesions. Atypical ocular bobbing occurs with anoxia and is non-localizing. In reverse ocular bobbing, there is a slow initial downward phase, followed by a rapid return that carries the eyes past the mid-position into full upward gaze. Then the eyes slowly return to the mid-position. Reverse ocular bobbing is non-localizing. Ocular dipping, also known as inverse ocular bobbing, refers to spontaneous eye movements in which an initial slow downward phase is followed by a relatively rapid return. Reflex horizontal eye movements are preserved. It usually is associated with diffuse cerebral damage. Vertical nystagmus, due to an abnormal pursuit or vestibular system, is slow deviation of the eyes from the primary position, with a rapid, saccadic, immediate return to the primary position. It is differentiated from bobbing by the absence of latency between the corrective saccade and the next slow deviation. Ocular palatal myoclonus. The palatal movement also is called palatal tremor, occurs after damage to the lower brainstem involving the Guillain-Mallory triangle, which extends between the cerebellar dentate nucleus, red nucleus, and inferior olive. It consists of a pendular vertical nystagmus, in synchrony with the palatal movements. Ocular flutter is back-to-back saccades in the horizontal plane and usually is a manifestation of cerebellar disease. Reflex ocular movements. Examination of ocular movement is not complete in the comatose patient without assessment of reflex ocular movements, including the oculocephalic reflex, Dahl's eye phenomenon, and, if necessary, the caloric, thermal, testing. In practice, the terms Dahl's eye phenomenon and Dahl's eye maneuver are used synonymously to refer to the oculocephalic reflex, which is the preferred term for the description of the response. This reflex is tested by observation of the motion of the eyes during sudden rotation of the head, by the examiner, in both directions laterally and then with flexion and extension of the neck, also performed by the examiner. When supranuclear influences on the ocular motor nerves are removed, the eyes move in the orbit opposite to the direction of the head turn, and maintain their position in space. This maneuver should not be performed on any patient until the stability of the neck has been adequately assessed. If there is any question of neck stability, a neck brace should be applied and caloric testing substituted. In the normal oculocephalic reflex, normal or positive Dahl's eye phenomenon, the eyes move conjugately in a direction opposite to the direction of movement of the head. Cranial nerve palsies predictably alter the response to this maneuver, Table 5.7. Clinical caloric testing, as distinct from quantitative calorics, used to assess vestibular end organ disorders, see Chapter 22, is commonly done by applying cold water to the tympanic membrane. With the patient supine, the head should be tilted forward 30 degrees to allow maximal stimulation of the lateral semicircular canal, which is most responsible for reflex lateral eye movements. After the ear canal is carefully checked to ensure that it is patent and the tympanic membrane is free of defect, 10 milliliters of ice-cold water is slowly instilled into one ear canal. For purposes of the neurological examination, irrigation of each ear with 10 milliliters of ice water generally is sufficient. Cold water applied to the tympanic membrane causes currents of endolymph flow in the semicircular canal, simulating a contralateral head turn. This results in a change in the baseline firing of the vestibular nerve and slow, tonic, conjugate deviation of the eyes toward the stimulated ear. In an awake person or a patient in pseudocoma, the eye deviation is corrected with a resulting nystagmoid jerking of the eye toward the midline, fast phase. Warm water irrigation produces reversal of flow of the endolymph, simulating an ipsilateral head turn, which causes conjugate eye deviation with a slow phase away from the stimulated ear. In an awake person or a patient in pseudocoma, the eye deviation is corrected with a saccadic fast phase toward the ear. By tradition, the nystagmus is named by the direction of the fast phase. The mnemonic cows, cold opposite, warm same, refers to the fast phases. Simultaneous bilateral cold water application results in slow downward deviation, whereas simultaneous bilateral warm water application causes upward deviation. Oculocephalic or caloric testing may elicit subtle or unsuspected ocular palsies. Abnormal disconjugate responses occur with cranial nerve palsies, internuclear ophthalmoplegia, or restrictive eye disease. Movements may be sluggish or absent. Sometimes reinforcement of cold caloric testing with superimposed passive head turning after injection of cold water into the ear may reveal eye movement when either test alone shows none. False negative or misleading responses on caloric testing occur with pre-existing inner ear disease, vestibulopathy such as that due to ototoxic drugs such as streptomycin, vestibular paresis caused by illnesses such as Wernicke encephalopathy, and drug effects. Subtotal labyrinthine lesions decrease the response. There is no response when the labyrinth is destroyed. Lesions of the vestibular nerve cause a decreased or absent response. Drugs that suppress either vestibular or ocular motor function, or both, include sedatives, anticholinergics, anticonvulsants, tricyclic antidepressants, and neuromuscular blocking agents. If the response from one ear is indeterminate, both cold and warm water stimuli should be applied to the other ear. If the test remains equivocal, superimposition of the Dahl's eye maneuver is recommended. The interpretation of abnormal cold caloric responses is summarized in Table 5.8. An unusual ocular reflex that has been observed in the setting of PVS is reflex opening of both eyes triggered by flexion of an arm at the elbow. This reflex is distinct from reflex eye opening in the comatose patient induced by raising the head or turning it from side to side. Motor system. Examination of the motor system of a stuporous or comatose patient begins with a description of the resting posture and adventitious movements. Purposeful and non-purposeful movements are noted in the two sides of the body compared. Head and eye deviation to one side, with contralateral hemiparesis, suggests a supratentorial lesion, whereas ipsilateral paralysis indicates a probable brainstem lesion. External rotation of the lower limb is a sign of hemiplegia or hip fracture. Decerebrate posturing is bilateral extensor posture, with extension of the lower extremities and adduction and internal rotation of the shoulders and extension at the elbows and wrist. Bilateral midbrain or pontine lesions usually are responsible for decerebrate posturing. Less commonly, deep metabolic encephalopathies or bilateral supratentorial lesions involving the motor pathways may produce a similar pattern. Decorticate posturing is bilateral flexion at the elbows and wrists, with shoulder adduction and extension of the lower extremities. It is a much poorer localizing posture, because it may result from lesions in many locations, although usually above the brainstem. Decorticate posture is not as ominous a sign as decerebrate posture because the former occurs with many relatively reversible lesions. Unilateral decerebrate or decorticate postures also are less ominous. Lesions causing unilateral posturing may be anywhere in the motor system from cortex to brainstem. Unilateral extensor posturing is common immediately after a cerebrovascular accident, followed in time by a flexor response. Posturing may occur spontaneously or in response to external stimuli such as pain, or may even be set off by such minimal events as the patient's own breathing. These postures, although common, may also be variable in their expression because of other associated brainstem or more rostral brain damage. Special attention should be given to posturing because it often signals a brainstem herniation syndrome. Emergency room personnel and inexperienced physicians may mistake these abnormal postures for convulsions, seizures, and institute anticonvulsant therapy, resulting in an unfortunate delay of appropriate therapy for the patient. Adventitious movements in the comatose patient may be helpful in separating metabolic from structural lesions. Tonic-clonic or other stereotype movements signal seizure as the probable cause of decreased alertness. Myoclonic jerking, consisting of non-rhythmic jerking movements in single or multiple muscle groups, is seen with anoxic encephalopathy or other metabolic comas, such as hepatic encephalopathy. Rhythmic myoclonus, which must be differentiated from epileptic movements, usually is a sign of brainstem injury. Tetany occurs with hypocalcemia. Cerebellar fits result from intermittent tonsillar herniation and are characterized by deterioration of level of arousal, epistotonos, respiratory rate slowing and irregularity, and pupillary dilatation. The motor response to painful stimuli should be tested, but the pattern of response may vary depending on the site stimulated. Purposeful responses may be difficult to discriminate from more primitive reflexes. Flexion, extension, and adduction may be either voluntary or reflex in nature. In general, abduction is most reliably voluntary, with shoulder abduction stated to be the only definite non-reflex reaction. This is tested in the comatose patient with noxious stimuli, such as pinching the medial aspect of the upper arm. Reflex flexor response to pain in the upper extremity consists of adduction of the shoulder, flexion of the elbow, and pronation of the arm. The triple flexion response in the lower extremities refers to reflex withdrawal, with flexion at the hip and knee and dorsiflexion at the ankle, in response to painful stimulation on the foot or lower extremity. Such reflexes seldom are helpful in localizing a lesion. Spinal reflexes are reflexes mediated at the level of the spinal cord and do not depend on the functional integrity of the brain or brainstem. Most patients with absent cortical or brainstem function have some form of spinal reflex. The plantar reflex may be extensor in coma from any cause, including drug overdoses and postictal states. It becomes flexor on recovery of consciousness if there is no underlying structural damage. Muscle tone and asymmetry in muscle tone are helpful in localizing a focal structural lesion and may help to differentiate metabolic from structural coma. Acute structural damage above the brainstem usually results in decreased or flaccid tone. In older lesions, tone usually is increased. Metabolic insults generally cause a symmetrical decrease in tone. Finally, generalized flaccidity is ultimately seen after brain death. Coma and brain herniation. Herniation syndromes are explained in Chapter 53. Knowledge of some of the clinical signs of herniation is especially important in the clinical approach to coma. Traditional signs of herniation due to supratentorial masses usually are variations of either an uncal or a central pattern. Classically, the uncal pattern includes early signs of third nerve and midbrain compression. The pupil initially dilates as a result of third nerve compression but later returns to the mid position with midbrain compression that involves the sympathetic and parasympathetic tracts. In the central pattern, the earliest signs are mild impairment of consciousness, with poor concentration, drowsiness, or unexpected agitation, small but reactive pupils, loss of the fast component of cold caloric testing, poor or absent reflex vertical gaze, and bilateral corticospinal tract signs, including increased tone of the body ipsilateral to the hemispheric mass lesion responsible for herniation, Posner et al. 2007. Signs of herniation tend to progress generally in a rostrocaudal manner. An exception occurs when intraventricular bleeding extends to the fourth ventricle and produces a pressure wave compressing the area around the fourth ventricle. In addition, when a lumbar puncture reduces CSF pressure suddenly, in the face of a mass lesion that produced increased ICP, sudden herniation of the cerebellar tonsils through the foramen magnum may result, Posner et al. 2007. Both of these clinical scenarios may be associated with sudden, unexpected failure of medullary functions that support respiration or blood pressure. In patients with herniation syndromes, the clinical picture may be confusing because of changing signs or the expression of scattered, isolated signs of dysfunction in separate parts of the brain. In addition, certain signs may be more prominent than others. Increased ICP invariably accompanies brainstem herniation and may be associated with increased systolic blood pressure, bradycardia, and sixth nerve palsies. However, these signs, as well as many of the traditional signs of herniation as described, actually occur relatively late. Earlier signs of potential herniation are decreasing level of arousal, slight change in depth or rate of respiration, and the appearance of a Babinski sign. Tonsillar herniation may be suggested by an altered level of consciousness, opisthatonic posturing, dilated pupils, and irregular breathing. These manifestations may occur in a paroxysmal fashion consequent to increases in ICP and have been referred to as the cerebellar fits of Hewlings-Jackson. It is important to suspect herniation early because, once advanced changes develop, structural injury is likely to have occurred. Subsequently, there is less chance of reversal. Differential diagnosis. Differentiating toxic metabolic coma from structural coma. Many features of the history and physical examination help to differentiate structural from metabolic and toxic causes of coma. Some features have already been mentioned. When the history is available, the patient's underlying illnesses and medications, or the setting in which they are found, often help to guide the physician to the appropriate cause. The time course of the illness resulting in coma can be helpful. In general, structural lesions have a more abrupt onset, whereas metabolic or toxic causes are more slowly progressive. Multifocal structural diseases such as vasculitis or leukoencephalopathy are an exception to this rule because they may exhibit slow progression, usually in a stepwise manner. Supratentorial or infratentorial tumors characterized by slow growth and surrounding edema may also mimic metabolic processes. The response to initial emergency therapy may help to differentiate metabolic or toxic causes of coma. The hypoglycemic patient usually awakens after administration of glucose, the hypoxic patient responds to oxygen, and the patient experiencing an opiate drug overdose responds to naloxone. In general, structural lesions have focal features or at least notable asymmetry on neurological examination. Toxic, metabolic, and psychiatric diseases are characterized by their symmetry. Bilateral and often multi-level involvement frequently is seen with metabolic causes. Asymmetries may be observed but generally are of small degree and tend to fluctuate over time. Many features of the neurological examination differentiate metabolic or toxic causes from structural lesions. State of consciousness. Patients with metabolic problems often have milder alterations in arousal, typically with waxing and waning of the behavioral state. Patients with acute structural lesions tend to stay at the same level of arousal or progressively deteriorate. Toxins may also cause progressive decline in level of arousal. Respiration. Deep, frequent respiration most commonly is due to metabolic abnormalities, although rarely it is caused by pontine lesions or by neurogenic pulmonary edema secondary to acute structural lesions. Funduscopic examination. Subhyaloid hemorrhage or papilledema are almost pathognomonic of structural lesions. Papilledema due to increased ICP may be indicative of an intracranial mass lesion or hypertensive encephalopathy. Papilledema does not occur in metabolic diseases except hypoparathyroidism and lead intoxication. Pupil size. The pupils usually are symmetrical in coma from toxic metabolic causes. Patients with metabolic or toxic encephalopathies often have small pupils with preserved reactivity. Exceptions occur with methyl alcohol poisoning, which may produce dilated and unreactive pupils, are late in the course of toxic or metabolic coma if hypoxia or other permanent brain damage has occurred. In terminal asphyxia, the pupils dilate initially and then become fixed at mid-position within 30 minutes. The initial dilation is attributed to massive sympathetic discharge. Pupil reactivity. Assessment of the pupillary reflex is one of the most useful means of differentiating metabolic from structural causes of coma. Pupillary reactivity is relatively resistant to metabolic insult and usually is spared in coma from drug intoxication or metabolic causes, even when other brainstem reflexes are absent. Hypothermia may fix pupils, as does severe barbiturate intoxication. Neuromuscular blocking agents produce mid-position or small pupils, and glutathione and atropine dilate them. Ocular motility. Asymmetry in oculomotor function typically is a feature of structural lesions. Spontaneous eye movements. Roving eye movements with full excursion are most often indicative of metabolic or toxic abnormalities. Reflex eye movements. Reflex eye movements normally are intact in toxic metabolic coma, except rarely in phenobarbital or phenytoin intoxication or deep metabolic coma from other causes. Adventitious movement. Periods of motor restlessness, tremors, or spasm punctuating coma often are due to drugs or toxins such as chlorpromazine or lithium. Brainstem herniation or intermittent CNS ischemia also may produce unusual posturing movements. Myoclonic jerking generally is metabolic and often anoxic in origin. Muscle tone. Muscle tone usually is symmetrical and normal or decreased in metabolic coma. Structural lesions cause asymmetrical muscle tone. Tone may be increased, normal, or decreased by structural lesions. The examiner should be aware of common structural lesions that mimic toxic metabolic causes and, conversely, toxic or metabolic causes of coma that may be associated with focal abnormalities on examination. Structural lesions that may mimic toxic metabolic causes include subarachnoid hemorrhage, sinus vein thrombosis, chronic or bilateral subdural hemorrhage, and other diffuse or multifocal disorders, such as vasculitis, demyelinating diseases, or meningitis. Any toxic metabolic cause of coma may be associated with focal features. However, such features most often are observed with barbiturate or lead poisoning, hypoglycemia, hepatic encephalopathy, and hyponatremia. Old structural lesions such as prior stroke may be the origin of residual abnormalities found on neurological examination in a patient who is comatose from toxic or metabolic causes. Moreover, metabolic abnormalities such as hypoglycemia may unmask relatively silent structural abnormalities. Detailed descriptions of the toxic and metabolic encephalopathies are provided in Chapter 53. Differentiating psychiatric coma and pseudocoma from metabolic or structural coma. The patient who appears unarousable as a result of psychiatric disease and the patient who is feigning unconsciousness for other reasons may be difficult to differentiate from each other. In such instances, the history, when available, and findings on the physical examination may suggest to the physician that a non-physiological mechanism is at work. Multiple inconsistencies are present on examination, and abnormalities that are found do not fit the pattern of usual neurological syndromes. Examinations of the eyelid, pupil, adventitious eye movements, and vestibulo-oculogyric reflex by cold caloric testing are especially useful to confirm the suspicion of pseudocoma. Eyelid tone is difficult to alter voluntarily. In the patient with true stupor or coma, passive eyelid opening is easily performed and is followed by slow, gradual eyelid closure. The malingering or somatoform patient often gives active resistance to passive eye opening and may even hold the eyes tightly closed. It is nearly impossible for the psychiatric or malingering patient to mimic the slow, gradual eyelid closure. Blinking also increases in psychiatric and malingering patients but decreases in patients in true stupor. The pupils normally constrict in sleep or eyes closed type coma but dilate with the eyes closed in the awake state. Passive eye opening in a sleeping person or a truly comatose patient, if pupillary reflexes are spared, results in pupillary dilation. Opening the eyes of an awake person produces constriction. This principle may help to differentiate coma from pseudocoma. Roving eye movements cannot be mimicked and thus also are a good sign of true coma. Finally, if during cold caloric testing, the eyes do not tonically deviate to the side of the caloric installation, and the fast phases are preserved, stupor or true coma is essentially ruled out. Moreover, cold caloric testing with the resultant vertigo usually awakens psychiatric and malingering patients. Helpful laboratory studies. Laboratory tests that are extremely helpful in evaluating the comatose patient are listed in Table 5.9. Arterial blood gas determinations rule out hypoxemia and carbon dioxide narcosis and help to differentiate primary CNS problems from secondary respiratory problems. Liver disease, myopathy, and rhabdomyolysis all elevate alanine aminotransferase and aspartate aminotransferase levels. Liver function test results may be misleading in end-stage liver disease because values may be normal or only mildly elevated with markedly abnormal liver function. Although the blood ammonia level does not correlate well with the level of hepatic encephalopathy, it often may be markedly elevated and thus helpful in cases of suspected liver disease with relatively normal liver function studies. Hepatic encephalopathy may continue for up to 3 weeks after liver function values return to normal. Thyroid function studies are necessary to document hypothyroidism or hyperthyroidism. When Addisonian crisis is suspected, a morning serum cortisol level should be obtained. A low or normal level in the stressful state of coma or illness strongly suggests adrenal insufficiency. Further testing of adrenal function should be performed as appropriate. When the cause of coma is not absolutely certain or in possible medico-legal cases, a blood alcohol level and a drug and toxin screen are mandatory. The results of these tests usually are not available immediately but may be invaluable later. Serum osmolality can usually be measured rapidly by the laboratory and may be used to estimate alcohol level because alcohol is an osmotically active particle and increases the osmolar gap in proportion to its blood level. Serum osmolality can be calculated using the following. Serum osmolality equals 2 Na plus MEq, L, plus blood urea nitrogen, milligram per deciliter. 2.8 equals glucose, milligram per deciliter, 18. The osmolar gap, which is the difference between the measured serum osmolality and the calculated serum osmolality, represents unmeasured osmotically active particles. Creatine kinase levels should routinely be measured in comatose patients initially and then at least daily for the first several days because of the great risk of rhabdomyolysis and subsequent preventable acute tubular necrosis in these patients. Measuring creatine kinase myocardial band MB, isoenzyme levels every 8 hours for the first 24 hours helps to rule out a myocardial infarction. Other useful studies. Electrocardiography. The electrocardiogram is useful to show myocardial infarction, arrhythmia, conduction blocks, bradycardia, or evidence of underlying hypertension or atherosclerotic coronary vascular disease. Hypocalcemia causes QT prolongation. Hypercalcemia shortens the QT interval. The heart rate is slow in hypothyroid patients with low voltage QRS, flat or inverted T waves, and flattened street segments. Hyperthyroid patients are generally tachycardic. Neuroradiological imaging. Once the patient is stabilized, necessary treatment is given, the initial examination is complete, and appropriate laboratory studies are ordered. The next test of choice is a CT scan of the brain, without contrast but with 5 cuts of the posterior fossa. Alternatively, MRI may be performed, depending on the clinical setting, the stability of the patient's condition, and availability. MRI provides superb visualization of the posterior fossa and its contents, an extremely useful feature when structural disease of the brainstem is suspected. However, MRI is not as specific as CT scanning for visualizing early intracranial hemorrhage, and it is limited at present by the length of time required to perform the imaging, image degradation by even a slight movement of the patient, and the relative inaccessibility of the patient during the imaging process. The CT scan, when performed as described, is currently the most expedient imaging technique, giving the physician the most information about possible structural lesions with the least risk to the patient. Repeating the scan with intravenous dye may be necessary later to better define lesions seen on the initial scan. The value of the CT scan in demonstrating mass lesions and hemorrhage is undeniable. Furthermore, it may demonstrate features of brain herniation. Uncal herniation is characterized on CT scan by 1. Displacement of the brainstem toward the contralateral side, with increase in width of subarachnoid space between the mass and ipsilateral free edge. 2. Medial stretching of the posterior cerebral and posterior communicating arteries. 3. obliteration of the interpeduncular cistern. 4. Occipital lobe infarction. And 5. Distortion and elongation of the U-shaped tentorial incisura. The clinician should be aware that the CT scan may miss early infarction, encephalitis, and isodense subdural hemorrhage. Special caution must be taken in evaluating CT scans in comatose patients, especially before lumbar puncture, to rule out isodense subdural or bilateral subdural hemorrhage. Interpretation of CT scans is discussed in Chapter 40. In severe head injury, studies of cerebral metabolism employing single photon emission computed tomography, SPECT, may be of prognostic value. Although cerebral blood flow in the first 48 hours after trauma does not appear to correlate with severity or prognosis, the cerebral metabolic rate of oxygen, CMRO2, like the Glasgow Coma Scale, may be useful in predicting prognosis. Electroencephalography. The EEG is helpful in many situations and disorders, including confirming underlying cortical structural damage in patients too unstable to travel to the CT scanner. Postictal states in patients slow to wake after a presumed seizure, partial complex seizures, electroencephalographic or nonconvulsive status epilepticus, as is seen in comatose patients after anoxic ischemic damage, and toxic metabolic disturbances. With metabolic disorders, the earliest EEG changes are typically a decrease in the frequency of background rhythms and the appearance of diffuse theta activity that progresses to more advanced slowing in association with a decrease in the level of consciousness. In hepatic encephalopathy, bilaterally synchronous and symmetrical, medium to high amplitude, broad triphasic waves, often with a frontal predominance, may be observed. Herpes simplex encephalitis may be suggested by the presence of unilateral or bilateral periodic sharp waves with a temporal preponderance. The EEG also can help to confirm a clinical impression of catatonia, pseudocoma, the locked-in syndrome, PVS, and brain death. EEGs are discussed further in Chapter 35. Evoked potentials. Evoked potentials may help in evaluating brainstem integrity and in assessing prognosis for comatose patients. A study of 50 hemodynamically stable patients remaining in coma 4 hours after resuscitation from cardiopulmonary arrest who were not treated with hypothermia with short latency somatosensory evoked potentials within 8 hours after arrest found that none of the 30 patients without cortical potentials recovered cognition. 5 of the 20 patients with cortical potentials recovered. 40% of the patients who did not recover had preserved brainstem reflexes, allowing some evaluation of prognosis in a group of patients in whom prognosis is difficult to assess by other means. There have been reports of patients with bilateral absent N20 responses treated with targeted hypothermia after cardiopulmonary arrest who made a meaningful recovery, with an estimated false positive rate of 2.2%. Event-related potentials may prove particularly useful as an objective assessment of cognitive function in patients with the locked-in syndrome. The N100 component of the auditory evoked potential and cognitive evoked potentials, mismatch negativity obtained after novel stimuli, appear to have predictive value for awakening from coma, but the pupillary reflex remains the strongest prognostic variable. Absence of evoked potentials in response to somatosensory stimuli also is highly predictive of non-awakening from coma. Intracranial pressure monitoring. ICP measurements provide an index of the degree of brain swelling and are particularly useful in the management of patients who have suffered severe head injury. Postmortem studies of fatal head injuries demonstrate a direct correlation between very elevated ICP and death due to tentorial herniation. The use of ICP monitoring in treating intracranial hypertension following traumatic brain injury significantly lowers mortality. Fariver et al. 2012. However, in the absence of intracranial hematomas, comatose patients with normal findings on brain imaging studies have a low frequency of increased ICP and almost never develop uncontrolled intracranial hypertension. Prognosis. In view of the current state of knowledge, outcome in any comatose patient cannot be predicted with 100% certainty unless that patient meets the criteria for brain death, as described later in the chapter. The available evidence is not sufficient to permit a definitive statement that a particular non-brain dead patient will not recover from coma, nor does it allow prognostication regarding how much recovery may occur in specific cases. However, general statistics on the outcome of coma, based on serial examinations at various times after the onset of coma, have been compiled and give the examiner a general idea of how patients may do. Although a variety of neuroimaging techniques, such as diffusion tensor imaging, positron emission tomography, functional MRI, and transcranial magnetic stimulation, have been proposed as tools to determine the conscious state and assist in prognostication, Large-scale randomized trials will be required before they are widely used for these reasons. Bodart et al. 2013. The natural history of coma can be considered in terms of three subcategories: drug-induced, non-traumatic, and traumatic coma. Drug-induced coma usually is reversible unless the patient has not had appropriate systemic support while comatose and has sustained secondary injury from hypoperfusion, hypoxia, or lack of other necessary metabolic substrates. Non-traumatic coma. Only approximately 15% of patients in non-traumatic coma make a satisfactory recovery. Functional recovery is related to the cause of coma. Diseases causing structural damage, such as cerebrovascular disease including subarachnoid hemorrhage, carry the worst prognosis. Coma from hypoxia ischemia due to such causes as cardiac arrest has an intermediate prognosis. Coma due to hepatic encephalopathy and other metabolic causes has the best ultimate outcome. Age does not appear to be predictive of recovery. The longer a coma lasts, the less likely the patient is to regain independent functioning. Factors that adversely impact brain injury following cardiac arrest include cerebral edema, pyrexia, hyperglycemia, and seizures. In the early days after the onset of non-traumatic coma, it is not possible to predict with certainty which patients will ultimately enter or remain in a vegetative state. In individuals who have suffered an out-of-hospital cardiac arrest, the combination of no pre-hospital return of spontaneous circulation, an unshockable initial rhythm, and unwitnessed onset by bystanders carries a very poor outcome in greater than 99% of the patients. An end-tidal CO2 value of less than 1.9 kilopascals, 14.3 mm Hg, after 20 minutes of cardiopulmonary respiration, CPR, also indicates an unfavorable outcome. Haengi et al. 2014. Although rare cases have been reported of patients awakening after prolonged vegetative states, patients with non-traumatic coma who have not regained awareness by the end of 1 month are unlikely to do so. Even if they do regain consciousness, they have practically no chance of achieving an independent existence. A large multi-institutional study determined that within 3 days of cardiac arrest, evaluation in the intensive care unit is sufficiently predictive of neurological outcome to allow for informed decisions regarding life support. Absence of pupillary light or corneal reflexes at least 24 hours after insult and no motor response to noxious stimuli no greater than limb extension after 3 days of observation suggest a poor prognosis for recovery. Other poor prognostic signs are myoclonic status epilepticus, bilateral absence of the N20 response from the somatosensory cortex, and several neuroimaging signs. Young, 2009. MRI of the brain has also provided assistance in predicting prognosis. Apparent diffusion coefficient, ADC, values less than 665 × 10⁻⁶ square millimeters, SEC correlated with poor outcome regardless of the time to MRI, with a specificity of 100% but low sensitivity of 21%. Wu et al. 2009. More recently, functional MRI has been applied to evaluating the patient with altered level of consciousness but continues to remain investigational. Traumatic coma. The prognosis for traumatic coma differs from that for non-traumatic coma in many ways. First, many patients with head trauma are young. Second, prolonged coma of up to several months does not preclude a satisfactory outcome in traumatic coma. Third, in relationship to their initial degree of neurological abnormality, traumatic coma patients do better than non-traumatic coma patients. The prognosis for coma from head trauma may be considered in terms of survival. However, because many more patients survive traumatic coma than non-traumatic coma, it is equally important to consider the ultimate disabilities of the survivors because many who survive are left with profound disabilities. The Glasgow Outcome Scale is a practical system for describing outcome in traumatic coma. As originally proposed, this scale includes 5 categories: 1. Death, 2. PVS, 3. Severe disability, conscious but disabled and dependent on others for activities of daily living, 4. Moderate disability, disabled but independent, and 5. Good recovery, resumption of normal life even though there may be minor neurological and psychiatric deficits. In their landmark 1979 report, Jennett and colleagues studied 1,000 patients in coma longer than 6 hours from severe head trauma. 49% of these patients died, 3% remained vegetative, 10% survived with severe disability, 17% survived with moderate disability, and 22% had good recovery. The most reliable predictors of outcome 6 months later were depth of coma as evaluated by the Glasgow Coma Scale, pupil reaction, eye movements, and motor response in the first week after injury, and patient age. Evidence of damage to the internal capsule, corpus callosum, cerebral peduncle, and white matter tracts on MRI in patients with traumatic coma carry an unfavorable prognosis. In summary, early predictors of the outcome of post-traumatic coma include patient's age, motor response, pupillary reactivity, eye movements, and depth and duration of coma. The prognosis worsens with increasing age. Cause of injury, skull fracture, lateralization of damage to one hemisphere, and extracranial injury appear to have little influence on the outcome. Persistent vegetative state. As a rule, chronic PVS can be reliably diagnosed 12 months after a traumatic brain injury and 3 months after other cerebral insults. Recovery after 3 years for patients in PVS has not been reported. Vegetative et al. 2005b. Those patients who have been reported to improve remain severely disabled, bed or wheelchair bound, and fully dependent on care. At 5 years, the mortality rate for PVS is in excess of 80%. Prolonged survival is rare and requires exquisite medical attention. Death typically results from untreated infection or overwhelming sepsis. Miracle awakenings, such as with the sudden appearance of communicative speech, have been observed rarely in patients in the minimally conscious state but not in those in PVS. Vegetative, 2005. Brain death. Clinical approach to brain death. A thorough knowledge of the criteria for brain death is essential for the physician whose responsibilities include evaluation of comatose patients. Despite differences in state laws, the criteria for the establishment of brain death are fairly standard within the medical community. These criteria include the following: absence of any potentially reversible causes of marked CNS depression. Such causes include hypothermia, temperature 32 degrees Celsius, 89.6 degrees Fahrenheit, or less, drug intoxication, particularly barbiturate overdose, and severe metabolic disturbance. Patients must be evaluated in the absence of sedatives and paralytics, allowing adequate time, which is typically 5 half-lives in the setting of normal hepatic and renal function for these medications to be metabolized and excreted. The absence of paralytic medications can be confirmed with peripheral nerve electrical stimulation, such as a train of 4. Coma. The patient should exhibit an unarousable unresponsiveness. There should be no meaningful response to noxious, externally applied stimuli. The patient should not obey commands or demonstrate any verbal response, either reflexively or spontaneously. However, spinal reflexes may be retained. No spontaneous respirations. The patient should be removed from ventilatory assistance, and carbon dioxide should be allowed to build up because of the respiratory drive that hypercapnia produces. The diagnosis of absolute apnea requires the absence of spontaneous respiration at a carbon dioxide tension of at least 60 mm Hg. A safe means of obtaining this degree of carbon dioxide retention involves the technique of apneic oxygenation, in which 100% oxygen is delivered endotracheally through a thin sterile catheter for 10 minutes. Arterial blood gas levels should be obtained to confirm the arterial carbon dioxide pressure. Absence of brainstem reflexes. Pupillary, oculocephalic, corneal, and gag reflexes all must be absent, and there should not be any vestibulo-ocular responses to cold calorics. The use of an automated infrared pupillometer that assesses pupil reactivity independent of the examiner is becoming increasingly more common in clinical practice. In cases of diagnostic uncertainty after the aforementioned clinical examination or based on individual hospital policies, ancillary testing to confirm brain death can be performed. These ancillary tests assess for electrocerebral silence. An isoelectric EEG should denote the absence of cerebrocortical function. Some authorities do not regard the performance of an EEG as mandatory in assessing brain death, and instances of preserved cortical function, despite irreversible and complete brainstem disruption, have been reported. Absence of cerebral blood flow. Cerebral contrast angiography or radionuclide angiography can substantiate the absence of cerebral blood flow, which is expected in brain death. These tests are considered confirmatory rather than mandatory. On rare occasions, in the presence of supratentorial lesions with preserved blood flow to the brainstem and cerebellum, findings on cerebral radionuclide angiography may be misleading. Despite aggressive therapeutic measures, maintenance of cardiopulmonary function of brain-dead persons for more than 1 week has been considered unlikely. In a series of 175 brain-dead persons with maintenance of cardiopulmonary function longer than 1 week after diagnosis, the potential to maintain cardiopulmonary function decreased exponentially with an initial half-life of 2 to 3 months followed at 1 year by a slow decline. Schumann, 1998. One patient maintained cardiopulmonary function for more than 14 years. Survival was found to correlate inversely with age, and prolonged survival was more common with primary brain pathology. The tendency to cardiovascular collapse in brain death may be transient and is more likely to be attributable to systemic than to brain pathology.